right? And they present very specifically, so you gotta know how men and women present. And it's not just galactorrhea, right? You have symptoms of low LH, so libido. For women, it's irregular menstrual cycles, menopause type symptoms, right? What lab do we use for prolactin? Prolactin, right? We should also make sure they are not pregnant. Check their thyroid. Why do we check their thyroid? We have to rule out hypothyroidism, so that's important. We went into how do we treat a prolactinoma? Yes, prescription. What type of prescription? So like our dopamine. If dopamine inhibits it, what med should we use? Yeah, dopamine agonist, right? Your propylene. If that doesn't work, we can have our surgery. Everyone remember that fun surgery, the transfemoral resection. So again, we kind of went through all the how they present with lab review, the treatment for that, for our acromegaly, which is what's in excess in acromegaly, growth hormone, right? And the primary reason for that is treatment for that is surgery. What about Cushing disease? So what's in excess? Cortisol, right? Hypercortisolism, and that's ACTH dependent from Cushing disease. 90% of the time in the dome disease, right? Cushing disease, dome, ACTH dependent hypercortisol, which means tells me in the name. ACTH dependent. So what's driving that high cortisol? Excess ACTH, most likely from an adenoma. Okay, and we'll talk about that again in lesson 5, so next week. What else did non-functioning? We talked about all the low, the anterior hypopituitarism, right? So in the hormone released from the pituitary gland are low by default, the target organ hormones will be what? Low as well, right? We talked about growth hormone, Sheehan syndrome, pituitary apoplexy, what else did we talk about? TBIs, all sorts of fun stuff. Okay, so remembering that, we're going to do a few check on learnings, if this works for me. And, okay, so first one is, I can't walk around, but I'm going to stay up here. So a 27-year-old male complains of worsening headaches, decreased vision for the past several weeks. On exam, you find mild gynecomastia. What's that? Breast tissue in a male, right? And you confirm bilateral peripheral vision loss. Otherwise, physical exam looks good. You do some imaging. You order a pituitary MRI, and it shows a pituitary mass or enlargement with encroachment into the sella turcica and the optic chiasm. What's the problem? What hormone is the problem? Everyone think C? Good job. Perfect. This is why male, because again, males it's that low LH, that high prolactin, also inhibits LH, that presents with the symptoms. And what else? That macroadenoma over 1 centimeter. He's having headaches, peripheral vision changes, right? And again, in males, most of the time they present with that macroadenoma type symptoms. Okay, this is the reason why it's not the other stuff, right? They just don't present as classic as they do with the prolactin. All right, next question. Which of the following would not be expected to increase prolactin levels? So this is a negative question. I do not ask these on the test, but I have fair game for this. So which of the following would not be expected to increase prolactin levels? Probably get it down to 50%. Yeah. Anybody want to guess?
D.
I like D. Anybody else? A? E? Okay. Let's see what it is. Sure. So it's E. So again, the reason is because in hypothyroidism, what increases? So hypothyroidism, primary problem is what? There's something going on here. We'll learn all the different problems with hypothyroidism too. But if it's primary hypothyroidism, not enough T4, so what does the hypothalamus and pituitary do? It increases TRH and TSH, and that TRH can do what? Increase prolactin. Is that cross-reacting? So that's why anytime we're working on somebody for possible prolactinoma, we rule out thyroid disease and we treat that first. Okay? And all these other things can cause it. But I guess not normally. I did add that word at the end. So. Okay, next question. A 42 diagnosed with a lactotrophic secreting microadenoma. What's that? Lactotrophic. What's the hormone? Lactin. Okay, perfect. I should know both. Which of the following is the best treatment? Somatostatin analog, dopamine agonist, transferal resection, radiation, or chemo? Bravo, all day. Perfect. Prescription, we know why. We can go back to the mechanism of action or the negative feedback loop. Perfect. This is why somatostatin analogs are good for acromegaly, right? It can decrease growth hormone if for some reason someone's not a surgical candidate. Transfetal resection is awesome, but it's second line for prolactinoma, right? Prolactinoma prescription first. And then radiation, not first line for any of our adenomas because of the damage it can do to the pituitary. And then chemotherapy, it's benign, right? So save that. 33-year-old females diagnosed with Cushing disease, ACTH-dependent hypercortisolism, Cushing disease. Which of the following is the most likely alteration in endocrine function for this disorder? What do you guys think? 90% of the time. No one's brave enough. Charlie, B, C. I like the differences. That's really fun. So you'll get it right. Oh gosh. My mouse is on the wrong side. It's gonna be rough. Whoop, there we go. Okay. B. So secondary hyperfunction, right? So what's Cushing disease? Where's the problem? In the dome, right? Pituitary. It's a hyper or hypofunction. Hyper, right? That's excess ACTH, excess cortisol. Ectopic is possible, but that's more 10% of the time. So again, secondary indicates pituitary problem. Primary would be where? Adrenal problem. Okay. More than Cushing's. Don't worry, we'll talk about this a lot, and you guys will be able to teach it to your dog or your cat or your kids or anybody who will listen to you talk about Cushing's. All right, and then here's the reason why it's not obvious. Right? Secondary pituitary hyperfunction. 44-year-old male patient presents with a history and clinical presentation of acromegaly. So you guys know all those classic signs of acromegaly, right? Externally and internally. Which of the following laboratory tests are considered the first line? I think this guy has acromegaly. What laboratory tests? We asked this on the first day. Or question like this. I heard C, correct, right? And because we can't just check growth hormone, right? Because it's a finicky hormone, it's pulsatile, comes out in pulses, it comes out when we're stressed, when we sleep, all of these things. So, and it's harder to gauge or get a good range when it's in excess. So instead we do IGF-1, and then from there we get a glucose suppression growth hormone test, right? So that's to help confirm it. Here's the reason why. Why it's not growth hormone. Helpful when it's in deficiency, but not first line for hyperfunction. Prolactin, definitely you can order it, but it's not diagnostic specifically for acromegaly. Testosterone, for sure you can check it, but again, not specific to acromegaly. And same with we don't test for GH. Okay. Which of the following terms describes an acute hemorrhage within a pre-existing adenoma? This is a few days ago, or well, 2 tests ago? 2 tests ago, so do your best.
Acute hemorrhage.
Which did we at least talk about? A, C, and E, so right there, right? Acute hemorrhage. E, pituitary apoplectic. Sudden death. And the big thing of this to understand what it is and then understand how they present. And then again, this is like is sick or not sick? Sick, right? We're talking about acute hemorrhage, pituitary. We need it, right? So this is a sick person. They probably have a history of an adenoma, but not always. And Sheehan syndromes can get apoplexy and things like that, but I would have to tell you, what about Sheehan? It'd have to be a female, right? She would have had to have a hemorrhage, needed some blood products during her delivery. And then here is the reason why. Don't pick B or D because it's Endo, okay? That's Rodner's territory and other people's territory.
Fooled me.
Okay. We're ready to switch gears. I guess technically continue gears. More thyroid stuff. I hope it's helpful that it's overlapping. I've seen the farm slides last semester, so hopefully this will be good. Okay. We talk about a lot. This is the biggest block of material. Sorry, biggest content in the block because this is the most common thing you're going to see. You're going to see thyroid disease more often than any other condition that we talk about. This block, okay? Active duty, retirees, kids. This is bread and butter PCM stuff. So we're going to go through some terminology. So just a review of hormones. We've been talking about these hormones since day one, so it should be a quick review. But TRH, the word releasing hormones in the name, so it comes from the hypothalamus, right? And then that tells the pituitary to do what? Release TSH. The pituitary also is triggered to release TSH on its, just based on the T4 and T3 levels. T4 is the main hormone that the thyroid produces, right? It's the primary hormone that is produced, and then it's converted into T3, which is your active form in the target tissues. So T3 and T4 are produced, but more T4, and then T3 is that active part in the cell. I think that's likely to be it. Right, so why do we talk about the thyroid? Why is it important? So I think of it as like a metabolic hormone. It has to do with energy, temperature, fat absorption, gluconeogenesis, just everything. So it's a big metabolic energy type hormone. And I think of it, I'm totally oversimplifying it, but I think of it as a dial, right? And you have this nice sweet spot homeostasis. And when you turn it down for hypo, things start to slow down. When you turn it up for hyper, things start to pick up, and we'll go through both of those today. Or sending you on your way. But essentially, it's important. Don't memorize all of that. Okay? Just instead, metabolic energy is important. Can't talk about a new topic without a feedback loop, but this should be review, right? You guys can teach this to me right now. When thyroid hormone is low, the hypothalamus and pituitary respond by releasing TRH and TSH. That goes through the bloodstream to the primary organ, which is the thyroid gland, and it tells those follicular cells to do what? Produce T4, some T3, and that is released in the bloodstream. And that once things are where they're supposed to be, we get nice homeostasis and we draw back on TSH, TRH. Don't know this? Come and see me. Don't be embarrassed because you need to know this. All right, so the best part about the thyroid gland in the labs match hormones. There's a few, there's like one lab, there's a few weird lab tests that you don't have to know all of them, but it's a beautiful thing. There's no growth hormone stimulation test, there's no cosinotropin, there's no osmolality, right? You guys are going to like the labs. So we're going to go over the labs, we're going to go over the imaging, and then we're going to talk about the disease. Okay? Sorry, I'm slow clicking today. It's not a regular PowerPoint. Okay, so TSH, single most useful thyroid function test, right? TSH is not only going to diagnose the thyroid disease, but in hypothyroidism, it's going to tell me if the patient is controlled, if I'm managing the right dose. So it drives your treatment as well. So diagnosis and treatment. So if all you're able to order is one single lab, order TSH. Okay. This high versus low should be absolutely reviewed. But again, primary hyperthyroidism, where's the problem? The problem's in the thyroid gland, right? Primary. And so it's excess. So if there's excess T4 and T3, what's TSH going to do? Decrease, right? If If I have a patient who's taking exogenous thyroid hormone, TSH will naturally what? Decrease because those blood levels are high with what they're taking. Same with panhypopituitarism. That one's a little bit different, so that would be secondary, right? So if the pituitary's falling, TSH would be low because the pituitary's falling, right? And then the opposite, primary hypothyroidism, where's the problem? Thyroid gland, right? This makes sense. There's not enough T4, T3 in the body, so pituitary response may increase in TSH. Secondary hyperthyroidism is something you learn about in school but you rarely see, but still important to understand. So there can be an adenoma or something triggering the pituitary to increase TSH, but it's super, super rare. All right. Questions on that? So favorite lab is TSH. We also have another lab. We can order free T4. It's great for screening hypo or hyper patients. So if you're worried about hyperthyroidism or hypothyroidism, you can add this. There are some, so like when I was at Colorado, when you ordered TSH, T4 came with it. It was a panel. So I ordered these together. I think in Genesis you have to order them separately. It's your choice. But absolutely, if you're working someone, if you really think have thyroid disease, you can order both. If it's just screening, you could just start with the TSH. What do you guys think when I say wellness labs, what's that mean?
General.
General, like you're coming in for wellness, you're 50 years old, you're going to screen for hypertension, high cholesterol, diabetes, all that. Should we add TSH to that too?
Yeah.
It's weird. So, okay, you will see, so you're going to see, when you're in clinic, PCMs order this all the time. But technically, the U.S. Preventative Service Task Force, I don't know if I forgot a word in there, they say there's limited data to show the benefits or harm for ordering TSH as your wellness lab. Okay? So for sure, if someone has fatigue or various signs and symptoms, you can order it. But you ultimately will one day, like sooner than you think, decide if you order it for your wellness or not. Right, the T4 now. Direct measure of unbound rate, it's the free T4, and then this makes sense. If it's low, hypo. If it's high, hyperthyroidism. Right? Very nice and easy. All right, T3. So T3, the only time you're going to order T3 is when you're worried about someone that has hyperthyroidism. I check this every time I teach, and all the societies out there say yes, only for hyperthyroidism. You will have patients who don't even have thyroid disease come in and say, I want T3, I want antibodies, I want that reverse T3, the total, give me, all the tests. Hold strong. There's no indication for them, especially if they don't have hyperthyroidism. And the reason is, so for hypo, when you have failure in the thyroid gland, T4 will decrease first, but T3, a low T3 is the last thing that happens. So again, it's not indicated for hypothyroidism based on the literature, but it's a good tool for hyper. Okay. I will not, when on a test, I'm just going to say T3. Technically, there's free T3, and that one supposedly is better, but not all labs order it because it's finicky. So then they have total T3, but there's drawbacks to that. It's total. So anyway, on the test, it'll just say T3. Okay. And then reverse T3, like I said, won't be on the test. But it's out there, and it's usually only like endocrine will order that. We're not an endocrine PA, so we're going to focus on what's going to be on the pants in real life. Thyroid antibody tests. Have you guys heard about these at all? So, because Graves' disease and Hashimoto's thyroiditis, these most common causes for hyper and hypothyroidism are autoimmune disorders. So, you have somebody who has hypothyroidism or hyperthyroidism. After it's shown, you've seen that through your TSH and your T4 and maybe your T3, then you can consider antibody levels. You don't just order these on general population because their grandma had thyroid disease. Okay, this is after. And technically, you don't need to order antibodies to make the diagnosis of hypothyroidism. Okay, does that make sense? So there's 3 different types of antibodies. You have your anti-TPO, which is most common in hypothyroidism or Hashimoto's. You have your anti-TG, which you can see in both. And then your anti-thyroid receptor antibodies. This one, 90% of people with Graves, this will be positive. All I need to know is that these exist. There's a panel, and you order it in real life. You order the panel, and all three get done, and then you'll pull up Hippocrates and think which one is what. But again, so these are a tool for you, okay? I don't expect you to correlate anti-TPO with Hashimoto's, but I might have it in this scenario. Does that make sense? But what do you order first? Alright, radioactive iodine uptake scans. You guys are IU for short. So do you touch on this, nuclear medicine in radiology? Maybe a little bit? Sure, right? Yeah. So essentially, it's pretty cool. A patient, what happens is they take iodine, and then they wait, I don't know, period of time, 6 to 8 hours, I don't know, probably shorter than that. And then they go and then they get this scan. And the iodine essentially acts, it shows thyroid function inside, okay? The thyroid gland loves its iodine, and so how much iodine is taken up corresponds to function, okay? So this corresponds to function. It can tell you size, it can tell you different things about nodules as well. So another tool, and we'll apply this to diseases, and we'll come back and get it all full circle, okay? I need you to know that it exists and kind of the reason behind it. So patients with hyperthyroidism or thyrotoxicosis, if you have a suspicious nodule, sometimes we use it for cancer or things like that. Into order. So high uptake, this is like pretty intuitive. So high uptake indicates what? Hyperactivity. Low uptake indicates low activity of the thyroid gland, right? Because it mimics function. So we will come back and tie, and you will leave this class understanding why you have an increased uptake in Graves versus a low uptake of thyroiditis as we go. Okay. But again, just remember it correlates with function. It should make sense. Okay, speaking of nodules, which nodules worse? We have a nice hot nodule on the left, and we have a nice cold nodule on the right. Which do you think? 50-50 shot, which is scarier? Cold, right? Because hot tells me there's function there, right? There's something going on. Cold, not so good. So not all cold nodules are cancer. Realistically, only 30% are cancer. But if you have a cold nodule, you're not done, right? You need to work it up further because it's more suspicious for cancer for sure. Hot nodules can be malignant too, but they're less likely. So here, I like this slide. We'll come back to it after we learn about the different disorders. But again, normal uptake in A, Graves' disease, hyperthyroidism, right? We're going to learn soon that it's this antibody party of thyroid hormone, and so that's why it looks like that, hyperfunction, and it's larger too, right? A lot of people with Graves will have goiter or enlargement or hypertrophy of the gland. Thyroiditis, we'll explain why it looks like this soon, but you have usually get from 0 to 3%, and then there's your lovely cold nodule that, again, you need to work up. That's it for scans. I won't be like, read this scan. It'll just be part of the story. But they're really important, so I still have to tie it to the diagnosis. I keep thinking this is like, is he always right here? It's because I can't move. So like, okay, sorry. Ultrasound. Thyroid ultrasound you're going to order way more often than radioactive iodine scans because hypothyroidism is more common. And you'll learn by the end of this that thyroid ultrasounds are they're indicated a lot more. But you order for goiters, for nodules, enlargements, things like that, and they help you identify if something is benign, just based on features, and needs further evaluation to see if it's cancer. Okay. The echogenicity, your ultrasound kind of determines if it's lighter or darker. You'll learn all of that in BMed. This is not a bedside ultrasound too. This is they go to the radiology department and get the ultrasound done. Okay, so and then those nice radiologists come back and give you a report. So, what do you guys see? Where's the thyroid gland?
They're purple.
So, it's your trachea, and then that's gland. I guess I have a mouse, huh? So, your thyroid gland on the side, your trachea, you got some vessels there, maybe the carotid artery. There's some important stuff right here, right? But luckily it's nice and anterior.
This is
So easy to view.
that made sense when she said that.
So here, what do you notice on this patient? Obviously, you want to do an actual thyroid gland. You check for lymph nodes, ask her some questions, get a good history, right? Get a good physical exam. What do you just see visually?
Goiter.
Yeah, goiter. Some asymmetry, right? It's a little bigger on the right, but absolutely goiter. So we do an ultrasound and we do a scan on this woman. We do labs first, because that we can do same day. And we get this. And what do you see that's different from the last one? At least, so this is hyperactive. They come in color too. But what do you see? It's bigger, right? So some enlargement on this side. Can you see my mouse?
Yeah.
Okay. Enlargement. There's your carotid arteries. We'll see later what nodules would look like. But yeah, it's no nodules, maybe, yeah. And then there you go. Okay. So again, another helpful tool. So I do an ultrasound or I do my scan and I see a nodule that's concerning. It's concerning based on what the ultrasound reads. What should we do next? How do I determine if it is cancer or not?
Yeah, biopsy.
We need the biopsy. So there's very specific biopsy we do. That's your FNAB or fine needle aspiration biopsy. I saw a lot of these done. They don't even numb the patient as long as they can stay calm. They don't even numb them, or at least they didn't in that endocrinology clinic. You lay there and ultrasound guided, they put the needle into the nodule and there's some suction with the needle. It's small, like 25 centimeter gauge, and then it gets I think it's like intermittent suction and it pulls that up. You send it to the lab and they tell you if it's cancer or not. So FNA biopsy, we will dive into that more of when to use it, but there's your introduction. All right. Feel good? Nice review. Maybe learn something. All right, so we're going to probably go to the break talking about all things hypothyroidism. Okay, so what's more common, primary or secondary? Primary, right? Primary. Secondary would be it's a pituitary failure, right? Primary, maybe the thyroid itself is just not keeping up with the needs of the body. So underproduction of thyroid disease. Again, primary is much more common. In the United States, the most common cause of hypothyroidism is something called Hashimoto's thyroiditis. We will dive into that. That's an autoimmune, basically a lymphocytic infiltration, which causes the failure of the gland to produce enough thyroid hormone. Globally, though, it's iodine deficiency. Why isn't that an issue here?
Salt.
Yeah, exactly. Maternal hypothyroidism. So I'm going to hit a pregnancy a few times in hypo and hyper. But what we notice is that women who have even subclinical hypothyroidism or true hypothyroidism, their babies can have some neurological delays or IQ issues. So we'll talk about how to prevent that. And then there at the bottom, yep, secondary. The hypothyroidism sure does exist, but you think I'm going to talk about it? We're not going to talk about it very much, except for in the anterior hypopituitarism. But for the most part, it's all primary. All right, so take a second on these symptoms. So remember I had this metabolic knob, this sweet spot, and we're turning it way down so things slow down. So I'm tired, lethargic, my bowels slow down, I'm constipated, I gain weight, I'm depressed. Could be anxious too, but typically more depressed. Cold intolerance, what's that? Does someone come in and say, I'm intolerant to cold? No. Or how would you ask somebody, how would you rule out cold tolerance? Yeah, are you cold when everybody else is comfortable? Are you hot but taking clothes off when everybody else thinks it's fine? You can have cold intolerance and not have thyroid disease. Have different internal temperature gauge, that's a common one. heavy menstrual periods. So menorrhagia, that's heavy menstrual cycle. You can have irregular or amenorrhea, but more common, you're going to have heavy dyspnea on exertion, joint pain, headaches, carpal tunnel syndrome. I mean, I thought every time I saw carpal tunnel syndrome in the clinic, I would check for diabetes, thyroid disease, and I have yet to catch either. So this is like 5% of the time, especially with Hashimoto's, they might also have carpal tunnel syndrome. And it might be due to like some edema and swelling that occurs with hypothyroidism. And then less common is specifically the hoarseness and dysphagia. So that's like you can get a goiter or enlargement with hypothyroidism, but typically it doesn't cause the crowding, or they don't have pain. So should be kind of review. We're turning that gauge down. If you like photos better, there's your picture. And then on physical exam, you see bradycardia, right? Thin braiding nails, thin hair, delayed relaxation of DTR. So you hit your DTR, they laugh, but it's a delayed come down. Okay, you have that. So again, it's slowing things down. Goiter. So you can have goiter in hypothyroidism, which is weird, right? I just told you the thyroid gland is failing. So why is it bigger? So the thyroid gland is failing. Pituitary sends more TSH. So that constant TSH stimulation of the gland can cause a little bit of hypertrophy. Okay, so not everybody has a goiter with hypothyroidism, but that's why you can get a goiter. Okay. Thinning of the eyebrows, galactorrhea, some cardiac stuff. Mixed edema coma is more an emergency scenario. We'll talk about at the end. We already talked about celiac disease. Back here on the left, the peripheral edema. You can see it. You rarely see it. Usually bradycardia, it's more the patient complaint than actual physical exam findings. But the puffy face and the yellowing of the skin and puffy eyelids is more when it's like severe, or it's just like been going on for a really long time. Labs. Yay, TSH. We know this already, right? We're going to test their TSH, and we can also check their T4, and it makes sense, right? TSH is high in primary, T4 is low. Right? Secondary, they're both going to be low, so your anterior hypopituitarism, but again, we're in the thyroid lab, thyroid course, so it's going to be high TSH, low free T4. There's your ranges. I give those on the test. One day you will just like memorize them. Like I can't forget the ranges of TSH because you order it so much. There you go. Here, if you like tables, labs, is your primary versus secondary, and it ties into the labs. Already talked about it. And then you might see, just for your situational awareness, they might also have some anemia. Probably the cholesterol. Cholesterol changes is pretty common with thyroid disease, but I'm not going to test you on that. Why does sperm morphology matter? Does it say sperm count? Like, we got plenty of swimmers. Why is morphology?
Fertility.
Yeah, fertility. You can have all the sperm count, the highest sperm count in the world, but morphology impacts how the direction and how they swim. You know, goal to so. RAS. So typically, again, just hypothyroidism. No goiter, no nodules, all you need is labs. If you have a goiter or a nodule, then you could do an ultrasound. Okay? We'll sum all that up by the end of the class. Okay, complications. So I have someone, again, with hypothyroidism, they don't have access to care, or they start medicine and they don't follow up. They're going to have cardiovascular disease issues later on. In fact, if you have someone who's diagnosed, new diagnosis of hypothyroidism, and they have significantly uncontrolled cardiovascular disease, you're going to have endo involved, because we don't want to be too aggressive on our thyroid hormone replacement, right? Our levothyroxine. Because if I overdo treatment, this person already has cardiovascular disease, I can cause some problems. Susceptible to infection, infertility, maybe super rare, and then the mixed edema coma or crisis is that thyroid emergency when stuff goes super low, and we're worried, we're admitting them. Okay. How do you treat hypothyroidism? We're giving them what they're missing, right? With that lovely levothyroxine, which you guys can teach me about at this point. So levothyroxine, we're giving them essentially, body's not making enough, so I'm supplementing that with this prescription. When I give it to you, it's a hormone, so it's not immediate, right? So I'm gonna give you, say, 50 micrograms, and I'm gonna wait 6 to 8 weeks to see if the dose I gave you worked. How do I determine if the dose I gave them works? Talk to them, I ask them signs and symptoms, but then what do I lean on? Yeah, one lab in particular in Money All Day is your TSH. I order T4 tube, TSH, right? And our goal, the whole point of this is to get them in a euthyroid state. How do we determine what's euthyroid? Well, they do a bunch of thyroid labs from a bunch of healthy women and men under 50, and the sweet spot is 1 to 3. So when I have a thyroid patient, a hypothyroid patient, I try to get them in that 1 to 3, even though the range is 0.4 to 4. But yeah, you have your sweet spot. That's not on the test. Sweet spot. What is the sweet spot? Okay. So, but that's what you're aiming to, that euthyroid state. So again, you have to ask them symptoms and things like that. So I give them 50 micrograms, and their TSH is still high. So obviously, I'm gonna do what with the dose? Increase it. But before I increase it, I need to talk to them. Are they taking it correctly? We'll review that. Are they taking it correctly, same time each day? Are they compliant? Are they taking it with other meds? Or are they doing weird supplements that help also increase or interfere? And then with low, if their TSH is super low, that's where you worry about if they're taking some kind of supplement that increases T4. Or are they doubling their dose? Patients do that. Less likely now. Definitely do that sometimes. This last thing, I don't know, did Farm talk to you about generic versus brand name Synthroid? So levothyroxine is generic, right? I give out 99% of my patients do fine on levothyroxine. But if you have a patient that just isn't, they're really hard to manage, and they're good on compliance, and they're just struggling, you can try brand name. And I equate it just like hormones are finicky and particular, and we do as best as we can with the generic, but every now and then you could try brand name Synthroid. That's not on the test, that's just like a clinical pearl. But yeah, there you go. Questions on Synthroid? It's a weight-based dose, so again, you can calculate the initial dose based on their weight. Typically, you start around 15 micrograms. If they're an older patient, you're going to be a little more cautious because as we age, what happens to the thyroid? It decreases. We don't need as much thyroid hormone, so we're going to go a little bit slower. And then as we age, we get cardiovascular disease. So I don't want to throw a bunch of hormone at this person and give them AFib just to keep them where a 40-year-old. Okay. So again, we're going to go a lot slower in women. These are, just a reminder, we're talking micrograms, not milligrams. Okay. So micrograms. And then we have that patient come back and they're compliant, they're taking their meds every day on an empty stomach, and it's still high. We're going to increase the dose by 12.5 to 25 micrograms. So what are the pearls, patient education pearls for levothyroxine? Do you guys know that yet? No. Okay, sorry. Soon. Maybe. You'll learn that next time. You'll impress me with your heart. Okay, so it has to be taken the same time each day. Endocrinologists want you to ideally take it in the morning, no food. So 30 to 60 minutes before food or your coffee with your cream or your macchiato, because those like minerals like calcium, iron, antacids, other medication interfere with the absorption. It's a hormone. It's finicky, so it has to be taken all by itself. If you have a patient that's like, I cannot take it 30 to 60 minutes before a meal because, I don't know, they get hangry, or maybe they have other meds or something, you can technically offer them to take it at night. But you want to, ideally 4 hours after dinner, 3 to 4 hours is great. But does that make sense? So again, morning, same time, not with other pills, on an empty stomach. And again, just like birth control, same time each day. Do you think that's hard for people to do? Yeah, it can be. For whatever reason, though, your hypothyroid patients are really but for whatever reason, people can't take amoxicillin twice a day for 10 days. We have studies that show we fail at that. But overall, they do pretty well. But anytime your TSH is off, asking the question, open-ended, how are you taking this? When are you taking this? What about your other meds? What about your vitamins? That sort of thing, okay? Any questions? So the bottom, it says, usually you have to stress this is long-term. A lot of patients nowadays don't want to be on any meds, right? They want to, how can I treat this without medication? Well, a lot, especially if you have autoimmune thyroiditis or Hashimoto's, most of the patients, this is lifelong. Not all, so you would monitor them. But again, educate them. Like, hey, this is something your body needs, but it's just unable to make some supplement. So maybe you can get some buy-in with that. But a lot of patients are on this chronic, especially if I caused the hypothyroidism because they had cancer and I removed their thyroid gland. Yeah. Those patients get it, right? The thyroid gland's gone. I'm going to be on levothyroxine. Go ahead. So these are the different dosing. All right, pregnancy. So I mentioned in slide 3 that the pituitary increases inside when you're pregnant. I also mentioned that people with subclinical hypothyroidism or known hypothyroidism, that their babies have a risk of IQ, lower IQ. So knowing that should make sense, right? As soon as a woman finds out she's pregnant, we need to increase her synthroid dose by 20 to 30%. And that's not, in practice, it's not that hard. I don't make you do that, but it could be just like increasing the dose a couple times a week. Maybe your weekend doses are higher. But again, 20 to 30% increase, right? Because we want to protect, one, just prevent any kind of miscarriage or things like that. But ideally, it's in a normal woman that doesn't have thyroid disease, when she gets pregnant, T4 and T3 demand goes up. But this is a normal woman, right? Her thyroid gland isn't keeping up normally, hence the synthroid, or the levothyroxine, sorry. So we need to increase that to 33%. Okay? And you know why. So you will have patients who are like, can you add T3 or Cytomel? Or you might have somebody who they've seen like not always a nurse practitioner, but like a homeopathic person who's like swears they need T3, but they don't even have thyroid disorder. I won't test you on that. I just want you to know that it exists. And again, usually endocrinology is starting it. It's just like a patient that's, for whatever reason, it's really hard to get them stable, so they'll add T3 to help, but that's not something on the test. Okay. And then armor thyroid. You have not learned this yet, yeah? Or you have? Okay. So every other class they learned it in pharm. Beat her this time. Okay. So armor thyroid is pig thyroid hormone. So they take it from the pig, and it sounds great, right? And patients who are on armor thyroid swear by it. They tried levothyroxine, they tried synthroid, nothing worked until they got their armor thyroid. They love it and they don't want to switch back. But guess what? All these medical societies say don't do it. In the United States and Europe, there's way more than that. It's not approved by the FDA, so don't ever, my recommendation, don't use it. Don't start on it. It's just unstable. There's more side effects. All of these societies say don't use it. We're better with our medication now. It exists. So last time I briefed this, and they were like, oh, pharm talked about it. And I was like, oh, I'm saying don't use it, and then you learn it in pharm. So sorry, don't. It won't even be on your test. But one of the students came up and were like, yeah, when I was in basic, a male, I was diagnosed with hypothyroidism. Anyway, for the most part, in clinic, you might just bridge them until they get to Endo. But yeah, synthroid. Okay. Sorry, my slide's clicking and going so slow. We'll do 2 more slides and then we'll be perfect. 3 more slides and then we'll get to a break. All right, when do we refer? They're hard to manage. All of you will manage your hypothyroid patients yourself. You don't need Endo. Unless they have cardiovascular disease, maybe if they have weird pregnancy history, you could loop in Endo, but it takes a long time to get an endocrinology, so you're going to be the one to increase their dose. or again, you're just struggling to get them their symptoms controlled and their TSH in that sweet spot. Okay, and then you admit them when you have this eczema crisis, which we'll talk about shortly. Right, big old 4-year situational awareness, subclinical hypothyroidism. You will see this all the time. What it is, they have high TSH, but their T4 is normal. Are you going to treat them? They're symptomatic. They have weight issues. They have constipation. Their hair is dry. Their skin's swelling up. Their mom has thyroid disease. Their aunt has thyroid disease. Are you going to treat them? So most of the time, it is yes. Don't test you on this, especially if they're younger and they're wanting to have babies and get pregnant, right? Fertility issues. A lot of times you'll see this in women over 60. They don't quite meet criteria. So you have to decide, am I going to treat this person or not? So, but I promise no subclinical. All right, give me one more slide, and then we'll stop. This is another FYI. So just, there's a lot of supplements out there, and people will you can buy some for yourself. And sometimes they use it because what you want, you have weight gain and hypo, so I take Synthroid, it's going to happen. Weight, energy, feel good, but it comes with side effects, and they're taking it like not monitored. So again, just FYI, ask about supplements. All right, we can take a break, and then we'll wrap up hypothyroidism when we come back. Does this work? Small and slow. Okay.
Animal time.
Solve this mystery. Cannibal sign?
Have this is the thing that that's what we were doing. Yeah. Last time my nieces were, they just waited, and my brother didn't went home. He bought the machine.
Yeah.
And so, and yeah, eventually they got to it. It was funny that it was the second oldest that helped out the most. Like, I can't tell it. She was like 7 years old, finally got it.
Some guys, at least I'll stay awake at 1700. I'll be awake. Yeah, what do you need? Shut up. Shut up. That hurts my ear. I was like, yeah, what do you need? I'm looking at that one for time. Yeah, it's a boy. Older day. It's a boy. Congratulations, you two. Wow, this will be fun. This will be better. Where do you learn this through? I don't know, man. We're start pressing harder. Wake up, sir. Oh, okay. Yeah, that's what I said. That comes in. Ooh. That's possible. The last guy just said it. That's right. He looks good. I saw Nate look at you. He was like, so this is it. This is why. Nate's just getting started.
My house right next to me. I'll tell you what they would do. I'm looking at houses in Grove City, like right below it. About an hour almost.
For what?
What shit is talking about?
Yeah.
Under fire right now. Security with Lisa. They don't know what they call it, but like how they go back and forth and change people's rating, like after you get rated.
Oh, I saw that.
And like they've been fired.
Where's this guy?
Back there. He said, yeah, he goes
Come on, I get a direct view, nobody blocking my view.
I can go right there.
Please don't.
Yeah.
I still don't understand how you can sit in that little tiny chair.
I mean, he's not saying that too long. It's like maybe for tests and like one lecture.
Yeah, it's about 1 hour in the morning.
That's really it.
I can't stand for hours. I can walk for hours, but I can't stand.
What?
Oh no, it's like very. It looked like when you turned that way, it looked like it was all gone. You only have like half, like barely half one.
You have a smell.
Yeah, did you like wipe your head at some point?
Yeah, I did.
Yeah, it's like barely even there. Like it doesn't even look. Yeah.
I just don't want to go sit. I'm not here.
Oh, okay.
But if you want to talk.
Oh yeah.
I would prefer not.
How was your wife?
She's good.
When did she already leave?
No, she doesn't leave till we're. I learned that the school. So after the school starts, her first week was our first week for senior. I learned it the week after. So
Oh, that's cool.
so I was originally gonna meet her down there. Like she was gonna drive down the week before, stay with her family, and then go to Miami the week after. And I would fly down and meet her down there. But now as part of what's gonna happen is I'm gonna drive with her down.
Wow.
Yeah.
That's gonna be a long
Yeah,
drive.
it's like 17 hours. I'm used to it.
I said, if that's like nothing.
And then I'll fly back at the end of the week. We'll start senior. Well, I have to be here.
On the way back, can you pick up a dog for me?
A dog?
Yeah.
I don't think I can get on a plane.
Oh, you're not.
Yeah.
I thought you were driving back.
Not like, cause like I'm driving with her in her car, her staying there, and then I fly back. You don't want a dog from here? You don't want a dog from here?
No. I need one of those, like, fence dogs. You gonna sit down? No, I was just wondering.
Why do you need a defense?
Because. Fine, I'll tell you no problem. Today. What did they try to bring to my face?
God or a person?
A person! A criminal!
Were you there?
If you had opened the door.
No, I'm not kidding. For real. Like, oh, okay. What would you do if you don't? That's what I was saying. I thank God that I wasn't there because I would have tried to open that door. Hello, how can I help you?
But yeah, like
No, I came back to the gym and the whole thing was out, and it looked like someone had tried to like forcefully try to break into the box. I did. I called the police. What do you think I am? Scary. A PA student.
Just on the bright side, only about a semester and a half left though. We got dry.
you have gas?
Not that. At least you get like someone. I have to like.
No.
No, I got like. Well, you get the money no matter what.
No, they don't give me the money. They're like, like kind of hotels and stuff. Where they used to.
A lot of my body
Or you
can
used to tell them like, hey,
I was using the wrong thing. I was like, wait. Thankfully, my wife, she loves to get kind of roasted. It works out.
Mine does it too, but she's all female.
It's so painful. She's like, stop. It's supposed to be sold.
One stop. It's like
Thank you for the heads up.
okay. So you're thinking of the really wrong thing. You don't get a whole reimbursement. You get a flat. So
She has done. She has done.
Two more slides. We're going to talk about keys, but I limited it to 2 slides. So this slide you have, I was wanted to delete. So skip, put it next. That's old. I guess I just forgot to delete it. And go to this. We have one page on creationism. So this is congenital hypothyroidism. So the word congenital, it's happening in utero, and it's just the failure of the thyroid gland to migrate to its normal location. So I know you guys don't have embryology. I didn't either, but I think it's really interesting. Anyone guess where the thyroid gland starts? Tongue, yeah. It's at the base of the tongue. And then as embryology happens, it migrates to the neck. So that's why when you have someone with, this is just like going off topic, but you can have a sublingual thyroid gland. So you have like a mass at the bottom of the tongue, and it's actually the thyroid gland. And then you can have the thyroglossal cyst. So someone comes in with like anterior neck pain, and it could be thyroglossal cyst due to failure in embryology. But creationism, back on track, is just essentially failure of the thyroid gland to work. And most common cause is a mom who is in with iodine deficiency, right? So are we seeing this in the United States? No, we're not. But again, because iodine deficiency is overall pretty common, we'll show you the map tomorrow. It does exist, and it's so important to catch this that we include it on our newborn screening. So anyone who's had a baby or been in the nursery when a baby's born or a day or two later, they do a heel prick. And it sucks because it's your own kid, but I guess any kid. But you do and there's a panel of genetic tests that they're screening for, and this is one of them. They're checking the thyroid because you can catch it at birth with like jaundice and abnormal like labs and things like that. But it can be delayed for up to 4 months after birth. Okay, and they have cognitive delay. They have a protruding tongue. They usually have a protruding belly, an umbilical hernia, which alone is in itself, poor muscle tone, and then a lot of them will be deaf. So again, not super common, but a pediatric presentation of congenital hypothyroidism. Much more common is your childhood hypothyroidism. And so that is your Hashimoto's, autoimmune thyroiditis, and they can be totally asymptomatic. So you miss it until they start to develop symptoms. And they might come in for your typical hypothyroid presentation, right? They're tired, maybe they're gaining weight, they have dry hair, brittle nails, constipation, but more specifically to kids, there's a lot of growth, right, in this adolescent period. So they're gonna be growing normal and then start declining in growth. Or a delayed puberty. Or they were doing really good in school and all of a sudden they're not. So it's affecting their concentration and their growth and puberty. So those are all red flags. Goiter is pretty common in these kids with hypothyroidism. And then the labs are a no-brainer, right? It's hypothyroidism. So elevated TSH, low T4, low free T4. And then we already know how to treat it, right? We're trying to get them back to that euthyroid state. And if we catch it early enough, we can correct the growth, right? As long as the growth plates haven't fused, we can get them back on track. So would you be able to tell the difference between this and this? Yeah. So they're pretty different. On a test, I know we get test spring, but don't remember this versus this. Don't worry, I get test spring too. I'm not trying to make fun of people, but all right. Questions on pediatric hypothyroidism? Okay. Switching gears to hyperthyroid, and then we'll likely stop because it's the afternoon, or when we get to thyroiditis, or like maybe 1 or 2 slides into thyroiditis. Okay. So what happens with hyper? What's wrong, right? Excess what? T4, T3, right? So terminology, I've seen, you saw it on a couple slides already, but the thyrotoxicosis refers to any clinical manifestation of hyperthyroid. So there's Graves' and there's thyroiditis and there's all these other things that can cause this hyperthyroid state, but that's that terminology, thyrotoxicosis. We're going to go through all of these etiologies, some in more detail than others, with the exception of the last one, the pituitary tumor secreting excess TSH, very unusual. Again, we'll dive through these. What do you think is the most common?
Graves.
Yeah, Graves, for sure. Graves is the most common. Before we dive into each one, how do they present? So, we have that metabolic sweet spot, the knob, and we turn it all the way up. And then we get hot. A potentially weight gain or weight loss, but I'm hot. I'm intolerant to the heat. I have exertional dyspnea. That you can see that in both. Loose bowel movements versus constipation, right? Fatigue, everybody in Endo is tired, right? So fatigue doesn't really help us. Palpitations do, right? That's unique. You don't see that in hypothyroidism. Restless, anxiety versus that like lethargy and depression in hypo. Menstrual irregularities, they're irritable. I'd be irritable too if I was hot all the time. Oh wait, that sounds like this class. Sticky. It's not hot today. And then they can also have a resting tremor. On exam, kind of goes along with that, increasing that metabolic knob, right? We're increasing this metabolic hormone, so you could see a tremor, moist skin, tachycardia, right? In hypothyroidism, is bradycardia, right? So paying attention to those vitals. Instead of we're gonna have with our deep tendon reflexes, we're gonna have a rapid relaxation versus the delayed, right? Goes along with the trend we're seeing. Goiter. So great, we can have a goiter with hypo, and now we can have a goiter with hyper. The cause for the goiter and hyper is because, especially in Graves, is that increased activity causes hypertrophy of the gland. We'll dive into that more soon. Hypertension, you can see hypertension is more common in hyperthyroidism, but you can see it in both. PACs and atrial fib. Does that make sense? Right? Maybe some SVT rates, but premature arterial contractions and atrial fib exists for sure. What's lid lag? Doesn't fit all the way. Yeah. Simply what it says. Just failure to fully close. And then this pretibial myxedema, it's a rash. It's very specific to Graves, just like the eye changes in Graves. And I'll show you a picture of that versus me to describe it. Nail changes in osteoporosis. So as osteoporosis, what happens is we have an increase in turnover, the osteoclasts turn up, and then so we have the bone mineral density decreases. So people with long untreated hyperthyroidism, we're going to maybe screen them for osteoporosis earlier. And then we'll talk about the exophthalmos that's commonly seen in Graves too on its own. These make sense though, right? Hyper and hypo, they're very different, they're opposites. They overlap just a little bit, but overall opposites. Okay, so the most common cause of hyperthyroidism is Graves' disease, okay? And it's much more common in females. It's an autoimmune disease, so autoimmune disorders are more common in females anyway. The funny thing, the most recent patient I talked to who had Graves was a male. The first goiter I diagnosed at a case was a male as well. So can't forget about you guys, but again, most of the time it's going to be females, 20 to 40. And what happens with this is that it's autoimmune mediated. So you have these receptor antibodies. They go into the receptors in the thyroid gland and they cause increased production of T4 and T3. So they have a thyroid party in the gland. So excess T4, excess T3. And that's why people with Graves' disease feel lousy. They really feel those palpitations. They'll be at the gym and where they're not even really breaking a sweat and super tachycardic. Or they're going to have dyspnea going up the stairs. So Graves is more symptomatic and it's because of that T3. And over time, as you're increasing production of T4 and T3, a lot of times the thyroid gland increases in size. So that's why you see a goiter, and why on that uptake scan you see increased activity, right? Thyroid party thanks to these receptor antibodies. Clinical presentation of Graves, we got that, right? Signs and symptoms of hyperthyroidism, we know that, from tremor to tachycardia to AFib, right? Lip lag, all of those. Goiter, you understand why. A lot of times they're asymmetric. Could have a buoy. Exophthalmos we'll talk about, and the skin changes that are specific to Graves. So this is your classic Graves eye changes with the ptosis, the inflammation, the protrusion. You have blurry vision. The bottom two are more significant. And then you can have the oncolysis, so it's like a separation from the nail and the nail bed, and that usually improves when you start treatment. And then here's that pre-tibial myxedema. I don't on my test, I don't put a slide and say, what is this? I put it as part of the story, but these three things are kind of high yield for Graves. And again, you have this rash. It's going to be, I guarantee their left leg would have usually the same rash. And it's red and thick, and swelling on the lower extremity. And then there's this guy, super, super rare, but you can have this arthropathy where their hands get really big, it's swollen, and you even see bone changes, changes the metacarpals, all of that. Crazy, crazy rare. It's going to happen to smokers, so I don't make you know that. Yeah, sorry. Oh, go ahead.
So just
I totally didn't see you, so let me know when you go back.
For goiter,
Yeah.
is it something that develops over the years, or is it months, or is it days from their onset of the
Great question. It's gradual. It's gradual. If you have enlargement more in a short period of time, we'll talk about that. But typically, it's gradual, and then you'll learn from these labs and from the exam, and the labs will help point to Graves. If you're still stuck, then you'll do a scan, and then it's going to confirm. Great question. So labs, low TSH, makes sense, right? Because we have plenty of T4 and T3 in the body. The pituitary's working, right? Where's the problem with Graves? Autoimmune attack to the primary thyroid gland, right? So T4 and T3 are high. And I'm going to put this in. Okay, so in Graves' disease, T3 is relatively much higher than T4. And that's one way that it stands out versus other causes of hyperthyroidism, is that T3 gets high, higher than T4. And that, it makes you feel real lousy. Probably correlates to the exophthalmos, the skin changes in that. If you do an antibody panel on this person, you would have the receptor antibodies are going to be positive in 90% of them. But you can't see all variations of the antibodies in Graves. And then you do this scan, and the scan is going to blow up. It's going to show increased activity, increased function, and likely increased size of the gland. Okay? And now we know why. Now we know why, because of this autoimmune, these antibody receptors increase the activity. Okay? If you have a goiter too, you could do an ultrasound of it as well. I'll talk about. All right, time to treat this patient with Graves' disease. They have high T3 and T4. They feel lousy. That T3 is even higher than the T4. Their TSH is next to nothing. It is time to treat them. So we split it up into three things. So medication, radioactive iodine, and surgery. talking symptom control. This person, what? They have a tremor. They're restless. They're anxious. It's like they're going to take a test, like an iPad test. They feel like that. They're sweaty, tachycardic. So what's a good medicine that we could use to calm that down? Yeah, beta blocker, propranolol all day long. So propranolol works great for symptomatic control. And sometimes we go kind of high on this, right? So we're going to go like twice a day dosing. You don't have to know dosing. We're not just like a little baby 10 milligrams. We're going to go high because they feel lousy. Now, do you think propranolol will fix their thyroid issue? It does not. So it is underlying multiple times, I guess. Symptomatic control only for, again, that restlessness and things like that. So what about those eyes, right? So we talked about these ophthalmos. More common in smokers. It's a little bit worse in smokers too. So obviously we want them to quit. But steroids, artificial tears too because of just the you can have chronic dryness and things like that. But steroids, especially before if you're going to do ablation, that can help. That's your main focus of the main purpose of steroids is to treat the eyes. And then we get to our antithyroid meds. Have you done this so far? Yes. Okay. So antithyroid medications in the United States, this medication is not considered a long-term treatment for hyperthyroidism. Of course, you're going to have that discussion with the patient, and you have shared clinical decision-making and all that. In Europe, they'll keep them on meds for much longer, but in the United States, this is not typically your definitive treatment. That's because these meds, you have to take them twice a day, sometimes 4 times a day. There's liver damage that can happen. And again, if you miss your dose, if you're somebody who's not compliant with meds, which is hard to with these, you're not going to have to feel so great. All right, so let's dive into these. So methimazole and PTU. So these inhibit T4 synthesis from methimazole. You usually go with methimazole. The male patient I was talking to is on this and propranolol. As the methimazole improved and decreased his T4, he lowered the propranolol. PTU, that one is great for a woman who is diagnosed with Graves' disease but interested in getting pregnant. It's safe for the first trimester. I don't have this on here, but it also usually in the second and third trimester they'll switch to methimazole just because of a lot of liver toxicity issues. PTU is also great in emergency scenarios when we get to that with thyroid storm because it blocks T4 and T3, or it blocks the conversion of T4 to T3 and the synthesis. So we like it in an emergency situation and P for pregnant. Okay. Side effects, sure. And then you will have 50% chance of remission with long-term therapy. So that's not super great. That also is why we don't. This isn't kind of definitive in the United States. And yeah, obviously maybe if they have mild symptoms of Graves' disease patients don't really feel well. So yeah, this is an FYI slide just because of time. We're going to skip it. Maybe they talk about it in farm, not here. All right. So what do we do for definitive treatment in the United States? So treatment of choice for people with Graves' disease is your radioactive iodine ablation. So radioactive iodine, we talked about radioactive iodine 1, 2, 3. So that's the scan to detect function. Iodine 131 kills it. So they take the iodine tracer and it destroys the thyroid function. And then it's gone. So then that hyperactivity is gone. But we're giving you radioactive iodine. So there's little limitations with that, right? So if you have small babies, or if you want to get pregnant, you can't. For males or females, can't have babies for at least 4 to 6 months. And if your patient's a female, yeah, anyway, just 4 to 6 months. We'll just keep it simple, okay? So there's risks for that. So you can see maybe ablation isn't for everybody. Maybe they want to do medication for a little bit and then go to ablation. We can't give it to you if you're pregnant or lactating. That's obvious reasons, right? We don't expose baby to that or other small children's. A relative contraindication is if you have somebody who's a smoker and they have the significant ptosis and the inflammation of the eye, you definitely want to give them steroids if you haven't already before, because this ablation can make their eye symptoms worse if they're a smoker, especially. All right, so I treated this patient. She's a patient. She doesn't have kids. She's not ready to have kids anytime soon. We do the definitive treatment of choice. We give her ablation. We kill the gland. What happens now? What does she now get for levothyroxine? We cause the hypothyroidism, right? We caused it by ablating it, and so we're going to give her levothyroxine. Why would we monitor calcium? Parathyroid, yeah, for sure. Parathyroid, which we talk about a lot in lesson 12. So maybe you have a patient who has Graves' disease. They don't want to be on meds long term. They have a bunch of babies. Their spouse is deployed. They want to get it treated, and they are they're a good surgical candidate. You can do surgery. So, so if it's patient preference, with like kid risks and things like that, or if they have like a really large goiter, you're worried about cancer, you could go to surgery as well. Okay. But no surgery. These are done all the time, but there's still surgery and it still comes with risks, right? So you have risks. You could damage the parathyroid glands. There's 4 of those right near the thyroid. You can do damage to that lovely recurrent laryngeal nerve that you probably haunted from ENT. I know they still talk about that, or Irving used to talk about that a lot. And again, when you look at the thyroid gland and the parathyroid gland on a diagram, it's different colors. Maybe the thyroid's green and the parathyroid's purple, but in real life, that's what it looks like, right? So there's just risk associated with it, but it's a good option for a patient. But again, oops, it doesn't work. Again, ablation is your treatment of choice. Surgery is another option. And same with the ablation, surgeries are the same, right? We have to treat them. They now have hypothyroidism, right? We caused it, so they will essentially leave the hospital with levothyroxine, which you guys know all about already. Complications. So if I have Graves' patients and I don't treat them, this should make sense. Cardiovascular risk, right? I already said they could show up with tachycardia and PACs and AFib. That can continue to have heart failure. Osteoporosis is a big one, right? I already talked about that. That high metabolic rate, you have high bone turnover, and then you have weakness of the bones. And these are in young women, right? We don't usually screen for osteoporosis, so that's a big thing. Talked about diminished sperm mobility in men, gynecomastia. Those things can happen if you have Graves' disease for a really long time. And then obviously the visual changes, skin changes, and then an emergency situation, something called a thyroid storm. So here is a flow chart. If this helps you, there you go. I'm not going to read it. Okay. And then we have apathetic hyperthyroidism. I think it's only one slide. So this is your elderly patient, and they present with hyperthyroidism, but it's more subtle. And they might come in for, they have like cardiovascular disease, and you're just like, why does this person have AFib? Or maybe they have a new diagnosis of depression or anxiety. This is on your radar. Don't worry about it for a test, but it's just like know it exists, I guess. Okay, so I want to just introduce thyroiditis, and then we're going to wrap it up. So maybe 5-ish minutes. It does involve me drawing a picture. Bear with me because this whiteboard thing doesn't work. So we'll see how this goes. I don't even know if I can because I'm not in real PowerPoint, but okay. So thyroid, are you guys familiar at all with thyroiditis itself? Is this a new term? Okay. We'll do a little intro and then we'll pick it up again on Friday. But essentially, you're going to have the term thyroiditis, inflammation of the thyroid gland, right? It's in the name. So there's various causes. It could be caused by a virus, a bacterial, or more commonly autoimmune disorder. And then there's also fibrous infiltration too to make things interesting. So we have inflammation and enlargement of the thyroid. And so when the thyroid gland is infiltrated, what it does is it immediately spews out any stored T4 and T3 it has. So it's infiltrated, And if I'm infiltrated, am I going to be working as well? No. So but before I start to fail, I have this release of my stored hormone. So that causes this variable hyperthyroid state. You have this hyperthyroid state where I dump out this hormone and I go here, but it's mild. It's not like Graves. So a lot of people don't even come in. And we'll go through each scenario of each one. But so you have this variable hyperthyroidism, and then it leads to transient euthyroid, but essentially it progresses to hypothyroidism. So you go from hyper to hypo. And depending on the cause, you might stay hypo, so in Hashimoto's, or the cells, the follicular cells in the thyroid, maybe from a virus, the virus comes and goes, and then it fixes itself. Okay? So these are the three phases of thyroiditis. And the scan can help distinguish between the two. So with Graves, it's more severe, versus thyroiditis, a little bit more mild, and the causes are different. So I'm going to see if I can draw on this or not. Okay. Oh, yeah. Okay. Yep. All right, so we are going to explain. Last time we did this, it kind of looked like a butt. It kind of looks like a butterfly. Okay, so here's your thyroid gland. And it is doing its thing. It's making its T4 and a little bit of T3. What happens in Graves again? The autoimmune thyroid receptor antibodies. What does it do? Yeah, they come in. We need a new color. Gosh, this is so damn slow. My clinical team knows I like whiteboards. So, okay, so the receptor antibodies come in and they attach to the receptors, and so antibody, 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 antibody. And what happens? More T. We have a thyroid party, right? And so that goes out into the body. So we have high T4, high T3, and what happens to the gland itself? It gets bigger, right? The goiter. When we do a scan, it's a party. Okay, cool. Next, thyroiditis. Let's pick a new color. I don't know if this will show. I don't think I am ADA compliant. My slide. Oh, there we go. All right, so we have we'll pretend that's a normal, non-asymmetric thyroid gland. So we have a normal gland producing mainly T4 and T3. And then it's infiltrated by a virus, a bacteria, or a different antibody. And you have this infiltration come in. Maybe it's a virus, a bacteria, or an antibody. God, this is horrible. Okay, and what happens, they're worried about function, so it spews this out. So all of the stored function goes out, and so we have this variable hyperthyroid, okay? And so they come in, and they're like, I'm a little restless, my watch is telling me I'm tachycardic, I'm a little sweaty, something's going on. You do labs, TSH as well. Variable hyperthyroidism. What is TSH? It's low. T4, T3 are high. So I have thyroid, but T3 isn't crazy high, and their symptoms are mild. Maybe they have a history of a virus or something like that. So then you lean on a scan, and you get that scan. But what happens? So this is dumped in the bloodstream, and while they're waiting for their scan in the thyroid gland, remember it's infiltrated by these viruses, this autoimmunity. So function starts to fail. So there's a disruption in the function itself because of this virus. So this leads to your hypothyroid state, right? And this is why when you do a scan, there's no uptake because you have this transient dump of my stored thyroid, and then now I have disruption. And so my thyroid gland isn't working as it's supposed to. So what happens? I transition to a hypothyroid state. Now, if it was a virus that caused it, if a virus causes it, well, luckily, what are viruses? They're usually self-limiting, right? I have a strong immune system. over time, it's gonna come back. Maybe it's postpartum, over time, function's gonna come back. But if I have Hashimoto's, it might come back a little bit, but not to the level where it needs to be, okay? So that is what, now you understand why in thyroiditis, you might be hyperthyroid, but you have low uptake, right? Versus Graves' disease, where it's that receptor party, okay? So there's the difference between those two. And then tomorrow, I'm running out of time. Up the goal. Tomorrow we're gonna go through these different types of thyroiditis. We're gonna go through goiters, nodules,